You're live. Greetings, everyone. We are honored to be joined here by three voices here who are very distinguished in the field. And I just want to introduce our event today before I introduce all of them formally. A very warm welcome to each and every one of you present here. My name is Meenu. I'm a counseling psychologist and the project coordinator at TherapHeal. We are gathered here today to address a vital question. What does it take to build mental health systems that are not affirming just in principle but inclusive in practice? While queer affirmative therapy has gained visibility within individual practice, questions of inclusion extend beyond the therapy room to the institutions that train practitioners, the policies that govern services, the frameworks that inform diagnosis, and the cultures that determine whose experience are recognized and valued. Welcome to Pride Roundtable 2026, Beyond the Individual Pouch, Institutionalizing Queer Affirmative Mental Health Frameworks. A conversation moving from individual allyship toward broader structural transformation where we will explore pedagogy and training, policy and institutional integration, addressing mainstream gaps and accountability in care. To address these critical domains, we are absolutely delighted to introduce an elite panel of pioneering professionals driving structural change across India. To begin with, a clinician whose career spans 4.5 decades and who has long carried this work from therapy room into the courtroom, Dr. Lata Hemchand, senior consultant clinical psychologist, founder trustee of Shloka Devaya Trust. She has over 45 years of experience in psychotherapy, clinical training, and mentorship. Trained at NIMHANS, she's retired as a professor at RFPG College and former secretary CEO of the Richmond Fellowship Society, Bangalore, and a founder trustee of Shloka Devaya Trust, a crisis counseling center for youth. Her practice spans family and marital therapy, psychosocial rehabilitation, HIV/AIDS counseling, and sexuality. A long-standing systemic advocate, as she gave expert testimony to Lawyers Collective opposing Section 377 in 2002, and in 2014 was instrumental in the Karnataka Association of Clinical Psychologists declaration to normalize LGBTQIA plus communities and ban conversion therapies. Guided by the belief that clients are our greatest teachers, she continues to write, train counselors, and champion empathetic affirmative care. Please join me in welcoming Dr. Lata Hemchand. Next, a
Thank you.
scholar and thank you. Welcome. Next, a scholar and educator who has built much of the language and framework for queer and trans affirmative mental health in this country. I welcome Dr. Ketki Ranade, Faculty, Center for Health and Mental Health, TIS Mumbai. Dr. Ketki has been teaching and researching queer trans affirmative mental health, law, policy, advocacy, and clinical social work. Trained at TIS and NIMHANS, Dr. Ketki worked for nearly a decade as a mental health practitioner, researcher, and activist, building services in low-income urban settlements and institutions such as the Beggars Home and Family Courts in Pune and Mumbai, before joining TIS in 2010. They authored Growing Up Gay, a critical psychosocial perspective, Springer 2018, led the Queer Affirmative Counseling Practice Resource Book, MHI 2022, wrote India's Trans Affirmative Mental Health Care Guidelines 2023, and edited a landmark Indian Journal of Social Work special issue on Queer Affirmative Practice 2022. They have served on Government of India committees for trans inclusion and were visiting faculty at the University of Gothenburg, Sweden. Please welcome Dr. Ketki Ranade. And our third panelist brings together medicine, storytelling, and advocacy, reforming what doctors are taught and what stories get told. Dr. Tirthankar Guha Thakurta, Assistant Professor, KPC Medical College, filmmaker and queer rights activist, advocate. Dr. Thakurta has been the guest faculty at Department of Education, Jadavpur University, and has been the visiting faculty of Department of Psychology, Calcutta University. A medical educator and filmmaker and queer rights advocate, he campaigns for a queer affirmative medical curriculum to root out stigma in medical texts and training. develops similar curriculums for AIMS, serves as a critical advisor on the Inclusive and Diversity Board at TherapHeal, and partners with organizations like Vartha Trust to expand queer friendly health resources. Frequently presenting on the journey of shame and resilience in queer life, he began filmmaking as a medical student, directing the acclaimed early short Piku Halo Ache on gay identity. And his post-COVID trilogy, Eka Duka Teka, reimagines iconic Tagore and Sarat Chandra characters through a queer and asexual lens. He is also co-founder of Balobhashar Pathshala, a free South Kolkata learning center offering mentorship and vocational training to underprivileged children and school dropouts. As part of an initiative by Association for Transgender Health in India, he conducted workshops with students and physicians across different aims centers to make the medical curriculum, campuses, classrooms, and patient care more inclusive to the LGBTQIA plus community and their issues. I will now hand the floor over to Dr. Ananya Sinha, Director and Chief Clinical Psychologist at TherapHeal, to lead us into this discussion. Dr. Ananya is a NIMHANS alumni with over 14 years of experience and practices as a queer, affirmative, and trauma informed practitioner. Welcome, Dr. Ananya.
Thank you so much, Meenu. Thank you for the wonderful introduction. And we are really honored at TherapHeal to have such an elite panel today. So without further ado, I think we will jump into the discussion which all our audience is waiting for. So when I was thinking about this roundtable, I think one of the things that sort of guided me into developing this was to ask ourselves as academicians, as clinicians, as activists, or as leaders, what is our responsibility? So if I ask you to finish this sentence in one breath, the mental health system in India is not safe for queer people because, what would your responses be?
You want me to go first?
Yes, ma'am.
Okay. So the mental health system in India is still not safe for queer people because many mental health professionals are still not oriented or educated about the inner world of the queer community. That's my
Right, right. And anyone would like to add anything to that?
Okay, you want me to go?
Yes, sure.
Okay, sure. Uh, so I think, I mean, I agree, and it is great to get started in a world, people being completely clued out sometimes. But I mean, saying that in another way, I think the mental health systems are not responsive and therefore not safe for queer people, primarily because mental health systems, and by that I mean curriculum, training, teaching, practice, policy, all of this is heavily rooted in cisgender heterosexual ways of being. And when I say cisgender, I mean the idea that there are only two genders and that people are born with two sexes, which leads to two genders, and they remain the same gender forever. So, cisgender and heterosexual. So, I think everything around us in the mental health space is cisgender heterosexually determined. And it's almost like, it's like the air we breathe, which you can't see, but it's everywhere. And so because these biases are there and because it's everywhere, you can't name it, therefore you can't change it so easily. So I think that's the reason why these systems are quite harmful even now.
That's so beautifully put, Dr. Ketki. When you say that, it's like the air we breathe, it is just everywhere and we are living in that space. Dr. Tirthankar, would you like to add anything to that?
I would closely echo what Dr. Hemchand and Dr. Ketki has mentioned. Uh, yes, there is a total invisibility and there is a polarization of the entire education, mental health as well as medical, towards the cis het oriented structures. What I see more problematic in this is not just the absence or deletion of the queer identity, but also an overall lack of skills of observation, perception, and empathy among the instructors and the students. Like when you are practicing a branch of science, if you call it science, it is all about asking questions. we have forgotten asking questions. And that is true for most disciplines of science that we nowadays recognize as natural or theoretical sciences. I think that is very problematic. You can train someone who is willing to learn. You cannot train someone who is not willing to learn, whose doors are already closed.
Absolutely, absolutely. I think today we are gathered here to ask those questions so that we don't forget asking the questions. And I think we are also highlighting two very important pillars here. One is education, and the other is system. So, when in your entire practice, has there been any young person, or any person for that matter, whom you couldn't help because the way the system was set up? You don't have to name them, you don't have to give a lot of background, but I am I think what we are trying to understand, what it might have cost them and what it had cost you. And anyone can go for it.
So I can go for it.
Sure.
So I remember
Please, please.
an engineering student who come to me, was brought by his parents because they felt that his behavior was not in keeping with their expectations. And the student had developed an infatuation for his lecturer. And initially, the lecturer showed a lot of openness and allowed him to talk about his desire. And after he opened up, the lecturer completely stopped interacting with him. And that affected his academics as well as his mental state. And that's when parents came. And the parents were very rigid to the whole concept of queerness, having an identity that was completely out of their understanding. And they were also not willing to look at it in an open way, even to help their son. And while he met me once or twice without letting the parents know, but I think the conflict he had between, because he was very attached to the parents, he was hardly maybe 19, 20, and he couldn't break away from them and to establish his identity. And he was caught in this conflict, and I think he attempted suicide. So yes, he was saved, but I think I lost him after that. I lost contact with him. So we can see how devastating the whole system makes the gay person feel, that he felt that there was no way out. So the heteronormative environment which was there in the family sort of brought out this. So I still remember that with sadness that this young person not be helped.
Thank you, Dr. Lata, for sharing it. And I'm sure when we sit here, and we sit here with silence, with sadness, with anger, with helplessness, we can recall many such stories which impacted lives in so many unbelievable ways, unacceptable ways, and maybe impacted our lives as a practitioner also. It makes us rethink about when we join a helping profession, we have a lot of idealistic things in our mind that this is what we would do. And then when we enter the system and we see, we don't even know where to start and how to,
Yeah,
even enter and intervene. That
true.
sort of is so difficult to process. Thank you for sharing that.
Welcome.
Dr. Tirthankar, you also raised your a hand. Anything you want to add to this and share anything else?
Since I have never actively practiced as such beyond my years of house staffship at the Department of Psychiatry, and then switched over totally to academics and teaching, so my counselings were more like an informal students counseling, which I used to do after my classes or between my classes. And also, the way I have framed the curriculum or used the curriculum to make the classes feel safe, and as a teacher to make myself feel approachable. The I will not name one particular person or individual. There has been, at least in the earlier part of my career, a large number of students who were queer, who at one point of the time or the other did come out to me. Then I found them gradually getting absorbed by the cis-het lifestyle, which they also at times expressed to me as very traumatizing. Probably I was not in a position at that point of time, also given the various other social legal scenarios then in the country, to probably extend to them that kind of a support that they really needed to become who they actually are. The saddest part is that they are there. They are living on this earth, doing something, living sometimes a life of facade, which they sometimes share with me. It is that very child who first came up to me expressing their queerness and probably expecting to be rescued and shown a way where they can have their own life. That child has been lost. I have lost those children in them. Now they are there, but they are a different person. And if they're happy, I'm happy for them. But I wish that those bright young children who came up to me seeking help could have survived.
The way you're talking about loss, it sort of makes us reflect that loss of a person can be of so many levels. Sometimes losing who that person is in the process of how the system and the society is designed is probably the biggest defeat that we, as even parts of the society, we experience. Dr. Ketki, anything you would like to add to that?
Yeah, I mean, I was just thinking about multiple stories that come to mind, but um, I'm also going to highlight, I mean, apart from the fact that we do meet people, and when I was training way back in early 2000s in NIMHANS, we do know that aversion therapy, conversion treatments were still used quite a bit, and they were not just practiced but taught as standard practices. And so there are stories of people going through some of these, but I also want to parallelly draw attention to some of the other stories. So I remember this one young person who came to Nimhan's behavior therapy unit. He was seeking conversion treatment. He wanted to get rid of his homosexuality because he couldn't live with the idea that he had these quote unquote perverse sexual attraction fantasies and so on. And I remember sort of waiting for him outside the behavior therapy unit. He was coming about 80 kilometers away from Bangalore. I was doing my intern. I mean, I was placed for my as part of my MPhil training at the behavioral medicine unit, and I remember waiting for him outside and handing him the a card for a helpline, which was a gay support helpline called Sahaya. It's still operational. Swabhava Trust in Bangalore still runs there. They've been running for more than 25 years. So I just want to highlight the fact that there have always been community responses. And I'm not saying that we've been able to reach everyone. And of course, systems have been fairly not just violent and discriminatory. And there's been a lot there. But I also want to highlight the fact that the queer communities, trans communities have been looking after themselves in the context of the fact that the systems have failed us. So we've always had lawyers, we've always had doctors, we've always had psychiatrists, we've always have had, and these are individuals. And so I'm not at all discounting the fact that systems have failed us, but also let's within that remember the hard work done by people from the community to look out for our own, like what Dr. Tirthankar was mentioning as a teacher, who is also a role model in some ways, is giving hope to that kid in the class that if this person's life is possible, my life might be possible too. And so in that sense, whether it is like setting up services or just like embodying this different way of being and just living your life, being a teacher, being a doctor, and so on and so forth. So I just want to highlight that as well, that while there are these stories of people we've lost, and I think that continues. Like when I think about this person from Tumkur way back in 2001, the example that I took about the behavior therapy unit, I think today, with the Trans Amendment Act that has come through in 2026, I am talking to young people who are asking me that now with this new definition of transgender, I may not be able to access the hostel that is meant for people who don't fit into the ladies hostel, gents hostel sort of a thing. So in the university where I teach, we have a gender neutral hostel, and so this person today asks me that if I am told that you have to bring a transgender certificate to be able to access this hostel, will I be able to access this hostel at all? And even here today in 2026, we are in new fresh ways once again failing our young people. So I just want to draw, I want to say both that that we've had barbaric mental health practices 20 years ago. Today we look upon that and we say, hey, all that is in our past, we don't do these things anymore. And we have new fresh ways of exclusion that keep coming up. At the same time, parallelly, there are people who people like Dr. Lata Hemchand, we've always thought of her as a hero. When we were studying, I was in Nimhans in 2001, and I had heard this sort of a bit of a legend, this story from my seniors who were doing their PhD then, that there's this person who was an alumnus of the psychology department who came to the department for some event, I think some celebration, and she came and publicly said that aversion treatment and conversion treatment should not be conducted. This was way back in 2000. So people like this have existed all along and who've really saved, I think, many people. Yeah, thanks.
Thank you, Dr. Ketki, for highlighting the stories of hope and also two sides of the coin. While we know that there are parts which are difficult and discriminatory and challenging in so many levels, there are always people to take care, and there are always people who are fighting for the community. I think Dr. Lata Hemchand had been that, she had been the beacon of hope and who had really fought. And in her introduction only, we were hearing about that. So we do have many, many, many such people who are silently fighting and supporting behind. One thing Dr. Lata highlighted at the beginning only, that one place where people, the queer community doesn't feel safe in the mental health system in India fails in the education. And we talk about queer affirmative care, and of course that we will talk in length about the education part as well. But when you hear about queer affirmative care, what is the first responsibility that comes to mind as a professional, not as an ally, but someone who teaches, treats, or leads? Dr. Ketki, would you like to respond to that?
Sure. So just a request, you can refer to me as Dr. KP. That's my preferred name. And in terms of responsibility, I think for me, it has been, the primary responsibility has been to create queer knowledge. And by that, what I mean is create knowledge from queer and trans lived realities, but also to sort of, I mentioned earlier about cisgender heterosexuality being like the air that we breathe. It's important then to name these norms. And I think that's one of the bits of pieces of work that I've been doing is to say, for example, that the child of child psychology is a cisgender child. It's important to name it, because there's an assumption that this child is growing up, whether we're talking about lifespan psychology, developmental psychology, or we are talking about this child and we are saying that, this child was given a sex at birth and then a gender was assigned to them, and all this is working out perfectly well, and they're going to grow up to become an adolescent and they're going to become heterosexual. And then there's going to be family and this and that. And so even when we're thinking about normative development, or we are thinking about clinical issues that will come up, and whether we're thinking of disorders, etc., our reference point is the family of family therapy is a Western nuclear cisgender heterosexual household. Yeah, the child of child psychology is a cisgender heterosexual child. So I think the primary responsibility, when I say when I think about QACP, queer affirmative work, is to build parallel and alternative knowledges, and to say, by that I don't mean that let's chuck all there is in psychological theory. But I'm saying something else. I'm saying that we will have to acknowledge for and start thinking about, so what does family life cycle stages that we learn in family therapy about, you have these this starts with, again, because mostly Western, it starts with courtship, and then married couple without children, and the married couple with the first school going child, and so on and so forth, and then to the emptiness syndrome. We have to think about something else also, for families that may not look like this. And that's not just about queer and trans people, that's also about single people, that's about really a whole bunch of people. People are talking about families of choice that people are making today, which are not families that are given to them either by biology or by birth or by marriage. So I'm saying that I think for me the responsibility of queer affirmative work is to generate this knowledge, and not necessarily only in clinical terms. So like one of the places I feel queer people are overrepresented is HIV research. I mean, I think HIV in some ways has been a great platform because it's helped in some ways for some realities to become, the world had to just take note of the fact that gay people exist in some ways because of the epidemic. But I think that that's one place where we are overrepresented, and today in some ways I feel suicide, some amount of literature on suicide, substance, depression, these are some places where with mental health disparities and LGBT, that's where we are being seen. But my responsibility, I feel, would be that I actually would like to think of family therapy, couple therapy, all of this work as also something that refers to and represents queer couples and families.
Yeah, right. It just reminded me of one of my clients who was based out of Germany, and he talked about his 5-year-old kid being introduced to the idea of family, and he was introduced to 9 types of family, and then it was asked, "Are there other forms of family that you can think of?" And everything that, and there were pictures. It was a pictorial book, and he could go through it. And I think he mentioned that it's such a wonderful way of introducing my child to a world, because this is the reality of the world. I don't want to give my child a tunnel vision of the world. So it sort of starts, it can start so early. And the earlier it starts, probably the more we will be able to change the air that we are living in, so that we can change the way we are, visualizing even small units and concepts. So thank you, Dr. KP. Uh, Lata ma'am, would you like to add anything to that?
I think since I come from the mental health uh, profession, I think I would just like to say that if we can sensitize the professionals towards, the uh, heteronormative environment which pushes people into living double lives because they're not able to come out, they're not able to get accepted. So, how all this impacts? So,
Hmm.
I think most professionals are not so aware of this. And I fully agree with Katie that we need to begin the education about that. We need to start a different chapter about
Hmm.
this particular knowledge. Yes.
Right, right, right. So sensitization again is one of the most important aspects of pure affirmative care. Um, One thing that, okay, maybe I'll come to that after asking Dr. Tirthankar about his opinion. Anything you would like to add?
Yes, I would like to again echo the reflection of all three of you. I mean, yes, there is a lack of uh, representation of the queer in the mental health setup, and also overrepresentation in domains like HIV, like sexually transmitted infections, etc. And as KP has rightly pointed out, historically, this has been a very complex journey of HIV and the queer movement going together. One has sometimes funded for the other because, directly speaking, on LGBT issues was not legal at that point of time. But it has also ended up pathologizing and pathologically connecting the two, as if the queer identity becomes a portal to the HIV disease. Yeah, yes, that has been there. Another very interesting thing that I have always noticed is in connection to what Dr. Ananya said, like, if a child grows up seeing a world which is very diverse, which is very colorful, there are less chances of this child, if there is a consistency in this learning, there are less chances of this child to think that the air we breathe around is only cisgender and heterosexual in nature. So it is knowledge, exposure, and sensitization from the early age that acts as a prevention. And I strongly believe that when we are talking about queer affirming mental health or medical health practices, the doctors today were not born homophobic or transphobic. In general, barring a few exceptions, I think phobia is also learned, it's also constructed. If we can train people to unlearn their phobia, we can train from the beginning to them to become inclusive. And so, although there is a lot to be done in the mental health sphere, looking at a very long term goal, I personally feel the journey begins in the family, in the lower schools, in the high school, and also in the non medical, non psychological fraternity. Much of the trauma and discrimination that a queer individual faces is right now probably not just from a mental health care provider and doctor. They are the last resort to visit after a lot of trauma has already been done. And it's also important to remember that the mental health practitioner is also a human at the end of the day. They also need to learn. So we cannot demonize them right away. I am not at all endorsing the acts of conversion and aversion therapy that they have done. But my question also is, were they trained or made to think into the fact that this is not right? One obvious thing that you can again ask is that, was it not very intuitive? And that was the question I started with. People are thinking less, and that is where the problem is. Dr. Ananya.
I com- I completely resonate with what you're saying. In fact, it just took me back to 2008 when I was doing my master's thesis, and I chose a topic. I was working on the quality of life of transgendered individuals, and when I came home and I said, "This is the topic I've chosen," my family was like, "Why?" And they just couldn't even the entire year that I worked through it. I remember even my guide told me, "Are you sure this is the topic you would like to work with? Because you will have to go and you'll have to." It was a qualitative work. I had to go and interact, and so much stigma. But instead of sitting with me and discussing why I chose it and what led to it, I think my family was more like, why did you have to choose this topic of all the topics? And I also would like to highlight Dr. Tirthankar. I knew him at that time, and he was the one who introduced me to different organizations and made me, he opened a new portal for me just to, understand the community much better. So thank him for that. But coming back to cure affirmative care, the other thing that bothers is also that when you talk about cure affirmative practice, at least in the mental health or medical space, it still is a choice. I can choose to train myself in QACP framework, and that also it's a very I think Memachai, Dr. Ketki she had led the entire training and developed the entire framework, but that is one of the most pioneer trainings, and people choose to be part of that training. So it's still a specialization, and it is still not mandated in our training. Is QACP framework, even as a module, being taught at any of the undergraduate, postgraduate levels? Is it mandatory when you become a practitioner? And if not, how do you view that? Dr. KP, would you like to respond to that?
Sure. I think to begin with, I think we've come a long way actually, because I do think that when I think about I mean, I'm again going to, I'm sorry if I'm embarrassing you, Dr. Lata, but I go back to early 2000s where, I mean, I remember being in a conference hall. It was, I think, a Karnataka Association of Clinical Psychologists meeting where they had called Vinay Chandran from Swabhava Trust, the person I
Yes.
mentioned who was running a helpline for more than 20 years, and a lawyer, Arvind Narayan, who has been quite a sort of eminent lawyer in the area of queer rights. So they were presenting their research. And one of the things that we heard from the audience was, I mean, I'm just taking this example to say how far we've come. So there's somebody who spoke about, somebody who's a behavior therapy, a person who's doing behavior therapy work and doing conversion treatments. He actually said that the tissue damage caused by anal sex is much worse than the tissue damage caused by using these electrodes when you do shock for aversion therapy. So I mean, it's just like, first of all, there's an assumption that anybody who's gay has anal sex, yeah, and that there is tissue damage involved. I mean, just it's so problematic at so many levels. I mean, yeah, so from that sort of a point, or later, I remember a study I did in Bombay and Pune on conversion therapy practices. And I mean, I'm sorry to use the word therapy. Someone told me in between, why do you want to legitimize this practice by using the term therapy? Why don't you just say conversion practices? So stop using this term therapy. So study I did on conversion practices, and I would ask people about whether they have had homosexual clients who come for seeking cure of their homosexuality, and everybody would invariably respond to that question by talking about male clients that they have had. Okay, so I eventually wrote a paper on it, which is called Medical Response to Male Same-Sex Sexuality. And the reason for this is nobody would speak about, and so even on probe, we would have a question that we would say that, have there been any instances of lesbian women who have come, either they have come or families have brought them for conversion treatment? And we've actually had, so I remember this one sexologist who's really famous, who would write in newspapers and stuff like that about how to live, whatever, like sexual, actually fairly sex positive messages for heterosexual couples. Yeah. And I remember his response when I asked this question about lesbian women and conversion. He said, I have not had lesbian clients, but I've had few couples who've come to me for sexual dysfunction problem. And in the woman's history, there was lesbianism in her history. Now, what does this mean? Like, here is a married couple who's having trouble having sex. She is telling you that she has had lesbian sex in the past. And yet we are refusing to say that this is a lesbian client. So, I mean, I'm just saying that is 2009, 2010. From there, where we've come today, I actually think that we are in it's a very hopeful space that we are in today. To respond to your question about is it mandatory right now, I'm not aware of any module on queer trans competencies either. I mean, I'm sure Tirthankar will tell us about medical education, but I don't think that we've had a couple of instances of the Madras High Court, for example, intervened to say that derogatory language about LGBT persons in medical text should be taken out, and then the NMC brought out a directive along those lines and asked for that to be done. I think there was also a court-ordered committee that looked at forensic medicine and psychiatry curricula to look at whether there were problematic ideas on LGBT persons who were there in that. So there is, I think, some of that, but I don't think it's mandated in curriculum or training. Some of us are doing. So I teach, for example, a course it's also an elective course. Huh? So I teach a 30-hour across 15 weeks, a course on queer-affirmative mental health interventions. I'm aware that apart from the QACP course that I started in 2019, I stopped teaching on that course after 2020. So I know that has been around and doing online courses and things like that. But apart from that, there are several other small and big sort of courses. But I would like to say that we've come some distance. Recently, the IPS, the Indian Psychiatric Society, has once again resurrected its LGBT task force, and there are some very promising people on this task force. So I'm sort of positively looking at that development. I must also say that in the context of the trans amendments, it's very heartening to see that one clinical psychology association, one psychiatry association, and today the psychiatric social work association all have come out with position statements saying that the amendments are quite they're quite negatively, they're going to impact trans folks. So I do think it's not, and I'm not saying that it's not compulsory yet, but I think there is changes happening in the discipline is one thing, but I also think that a lot of people are, there's a lot of social learning. So if you have a young person today coming into a medical classroom or a psychology classroom, they're already sort of clued in to some of the terminologies, identities. They probably watched a couple of films. So culturally, a lot of stuff that is shifting. So there's a lot of social learning apart from. So in some ways, I think our training is lagging behind. So we are not doing enough in terms of competence building for. But I think culturally and socially speaking, people are already sort of a little more clued in than they were, say, 10 years ago.
Hmm. I completely agree. I think we have come a long way, particularly in terms of how things were and how things are now. Dr. Tirthankar, is there anything you would like to add in terms of the medical aspect that Dr. KP said that she's not aware of mandatory trainings yet? There are elective courses and many other courses. What about the medical scenario?
Yes, again, in the medical fraternity, I think the medical fraternity, in terms of the queer issues, always lag behind the humanities. That is a norm of natural sciences, that they love putting labels and boxes over everything, and probably they survive on that. I mean, um, one good thing that has happened post the 2018 partial reading down of Section 377 and a number of court orders that came out that KP mentioned, that the forensic books have been rewritten. Yes, that's true. But the problem is that the printed curriculum always does not correspond to the practiced curriculum. So there may be certain changes that are done in the book, but how far it is being actively taught in the class and also actively sought in the examination, that is very important, because students will only learn those aspects which come in the examination. Not all students are scholars. Not all of them are nerds. Most of them study to pass the examination. So I think the teachers should be setting questions on the so-called pathology of homosexuality and the illegality of homosexuality, then suddenly silently changing the line in the textbook and not even speaking about it in the class and examination does not undo the harm that decades of this colonization and queer bashing has done to us. So I think that is one important issue. Second, it's not mandatory. I think in India, most ethical things are not mandatory. It's mandatory to be technically correct over the papers and everything else. And that's how things work, unfortunately or fortunately. Yes, so in Calcutta University and Jadavpur University, when I designed my part of the courses on certain postgraduate counseling courses, I make it very official to keep a section on queer issues, including queer affirming practices, and at least 10 to 20% of the course time is dedicated to that. The part only that I overview, that's only a very small part with small number of students, like say 50 or 100 passing every year. But the bigger picture, I am also sure that many individuals also in their own capacity work in the way I work. So it is only with individual initiatives that things are happening. But the National Medical Commission or the West Bengal State University of Health Sciences or the individual colleges do not have any mandate regarding queer affirming practices. No, they do not have.
Right, right. So, in this situation, Dr. Lata, so if there is a therapist who was never taught because it was not mandatory, was not taught in queer affirmative practice, and they meet a client, a queer client in their practice, what does that absence of mandate cost the client?
I think uh, the most the, uh, damaging thing that can happen is the bias of therapists coming into play. And of course, the queer person is going to feel uh, unsafe and also probably not being able to affirm themselves as much. So the whole purpose of therapy, I think, would be diluted, and and we don't know what kind of biases can come up from the therapist if they have no knowledge of this or if they are not trained.
Hmm.
I think
Hmm.
that would cause a lot of damage,
Hmm. Hmm. Hmm.
and
Right.
and I think we have examples of those as well, among clients who have had this kind of experiences and have got into depression, got into panic attacks, things like that.
Exactly, exactly. So somewhere I think I'm also steering a little bit towards training because I felt in my training, at least during all my years of training and practice, that because it was never mandated, it was always about a very self motivated learning based on whatever resources available. The QACP resource book had been amazingly helpful, I think, but it also came after, I think, 10 years of my practice that I had a resource book which sort of helped me in that. So that made me reflect that if there was something which was a part of the training, had I as a therapist been different and had the entire, the clientele that I had um, been with, had their journey been different. Uh, Dr. KP, you wrote the resource book that rest of us trained from you, and it was distilled from training over 350 practitioners across 40 locations in India, if I'm not wrong. So, when you compressed all that into one model, what is that one single thing in affirmative practice which practitioners most consistently get wrong and which is the most difficult to train?
At the QACP resource book actually is a result of several research studies, including those with mental health professionals. So there was one I did in 2011-12 with professionals who have already been, I mean, Tirthankar and some of these people or people I met in that context for the first time, that there were these people who are doing this work in small ways in different parts of the country. And so we tried to collate some of that into good practices of working on gay affirmation. At that point, we were not talking as much about trans issues in 2010-11. But later I did a more recent study with 165 mental health professionals in Bangalore, Bombay, and Delhi. So the resource book is a result of actually many of these things. But to respond to your question about what do people get wrong, I think especially in the context of training, I feel one of the things is that generally mental health professionals have this notion that I'm trained to be non-judgmental. Yeah. And so therefore I think I'm okay. So if I believe that I am a decent liberal human being, mostly who has, is open-minded, and I'm trained to be non-judgmental, I should be okay. I mean, there's nothing for me to do in terms of getting trained specifically on LGBT affirmative, etc. I'm okay with, whoever you are, you do your thing. I'm okay with that. But I think the core of this is actually, and the example I'm going to take is not from queer affirmative, but actually methodology courses that I teach. I teach research methodology courses as well. So we take this example of saying that it is a perspective that matters when you're doing research, and we ask this question that if you are viewing a table from on top. And if you had to describe this, you would say, what is this? You talk about four legs and one surface, and you would refer to this as table. Now, think about the fact that if you were 2 feet tall and if you were to look at the same thing, you would probably call it a roof, right? As four things on top of which there is a, right? So this is about perspective. From where are you seeing, right? And I think one of the things that's very difficult, particularly for people who think that what is this newfangled fad about LGBT affirmation? Everybody, there's a lot of fads, and I think LGBT affirmative is a big fad also, which is, I mean, the reason you say, Ananya, you heard about it only the queer affirmative QACP book came out in 2022. We had written one called Gay Affirmative Counseling Practice in 2014. It was just not backed by a corporate brand, and so therefore not everyone knew about it. Okay.
Okay.
So today, in some ways, it is a corporate brand and it is a fad. Like you have trauma informed and all of that, right? So many people therefore feel that this is this new thing that has come up. But I think it is actually about, are you looking at this from top or are you looking at from bottom? It is actually, it's a perspective, complete different perspective. So for example, things like, so we do a interesting exercise in the QACP course. We ask people that spend a whole day in your life where you don't make any reference to your sexuality. Huh? means you cannot make any reference to your relationships, whether you have a child, and so on. You can't make any of those references, which means you can't say simple things like, I had to get up at 6:30 today morning because I had to make tiffin for my son who had a school picnic. You can't make that because that's a reference to your sexuality, right? So we ask people to live a whole day like this, where you don't make any reference to your sexuality or to your relationship, and repeat this on a festival day. Yeah. And there you are suddenly 2 feet tall and looking at it as a roof and not looking at sexuality anymore as a table. Yeah. So, I
Right.
mean, I think so. These are just some examples of, I ask people about, so for example, weddings, festivals, these are all very often where people will tell you that those are moments of great panic and discomfort. Yeah. Now, Dr. Lata started us by saying that inner world of for a lot of people I know, going to a wedding means having to face the question about when are you now. Or having to dress in clothes that you're terribly uncomfortable in, because there's a gender script of what a shadi or what Diwali looks like and what kind of clothes are you supposed to wear because of the gender given to you, right? So these are like very difficult moments to navigate. They're just few examples of the inner world or the lived realities of queer and trans people. So yeah, so I'm just saying that what people get wrong is to not it's difficult to understand why is this important. I might have a PhD, 10 years of clinical experience or whatever, 40 years of clinical experience. It is important to people may often think that I am trained to be non-judgmental, I'm clinical acumen is very good, so I don't need this all this new fad of this new generation. So yeah.
If I
Right.
can add something more to K- KP, I think she is my hero. Like the amount of work she has done, training people and coming out with the manual. I think it's a wonderful work. But what I would like to add to what she was saying is, I think to be truly affirmative, I think you just have to have the lived experience. So when you just leave your armchair as a psychologist and just get into the community, just go to the gay bars, just listen to their narrative, and I think when you just live with them, that's when your whole attitude, your approach, everything changes. The perspective changes.
Absolutely, ma'am. I think 2008, the master's thesis that I was talking about, when I went to the first organization that I would like to collect data, this is the research I'm doing. They said that we will give you whatever you need. We have only one condition. You have to spend one day with us. The entire day, you will have to be with us. And whatever we do, you have to do with us. That one day changed the entire lens for me, because it was, the us and we thing shifted, because I was with and like I have always read about transgendered individuals. I had read so many articles. I felt that, okay, like Dr. KP said, that I felt I knew. And then I actually experienced life the way it is experienced by the community. And it was so different. And that shifted. And that kind of exercise, I think, is really like the lived experience. It shifts things. So completely resonate with that.
So I think when we formulate courses, somewhere we have to give this opportunity for whoever it is who's getting trained to have a
Right.
lived experience. Like you said, one day with just spend with the community.
Right.
Yeah.
Right. Yeah. And of course, the perspective part, it's also very important that we had a poem called Six Blind Men. And the poem was like about, six blind men would go and meet the elephant. One would say, oh, the elephant is like a rope. The other would say, the elephant is like a fan. The other said, the elephant is like a wall. And they started fighting. I think we are also doing the same thing. Sometimes we are so rigid, like, this is what I see, that we don't focus on what we are not being able to see. The perspective shifting probably is all not shifting. It's about ability to take in different truths in the same situation, which are different perspectives in the same situation, probably also is a part of the pure affirmative or any affirmative training for that matter. So the other thing, Dr. KP, is in your Growing Up Gay book, you have questioned whether Western coming out and identity development models fit Indian queer lives. So, where does importing those frameworks quietly harm an Indian client, and what should a curriculum teach in their place?
So that's a specific reference to LGBT psychology. At some point of time was there's actually no one Western model, na? But at one point LGBT psychology was quite obsessed with the idea of coming out. And there was this notion that people who come out are it's really integrated, well integrated, people with pride and so on and so forth, and those who don't come out suffer from loneliness and internalized homo prejudice and things like that, right? So that's one of the things I'm questioning, because actually what you see is in the Indian context, I mean, and there are multiple levels to this. So for example, lesbian women, you'll hear again and again many stories where people will say that they can't afford to come out because there'll be too much violence. They probably face conversion happens in many ways. Na? Forced marriage is one way in which you convert queer people, right? So coming out might be harmful. It's nothing to do with internalized homo prejudice or negativity or what sometimes we call homophobia. So it might just be about escaping violence. And so you might use the cover of I need to study in a big city, or I need education or jobs as a cover to not come out and just escape. So yeah, that's those are some of the things I'm dwelling on in that chapter, where I'm saying that it's much more complex than to say that coming out is the ultimate. Like, then even therapists will have this notion that if I have a gay client, my job is to help this person to be out and proud as gay. That need not be a parameter of success. I mean, that could be a goal for the client, and yes, of course, you will have a role then to support them, help them, with various strategies that you may have, therapeutic and so on. But yeah, so that was a critique of, and the idea that the person who's not come out is somehow this depressed, poor sort. Whereas, you have a lot of people who continue to live, very, very happy queer lives while living with their parents, not being out at all. The other thing I say in my book is, in a culture that is extremely homosocial, which is basically we are as a culture extremely scared of genders mixing. So we have a problem with, if you're going out for a late night film, you're going with a boy, that's a problem. But, you're going out with your same sex best friend, no problem. So, it's an extremely homosocial. So men being together, best friendships, women being together, all of that is not seen as, anything weird. So you will I have had narratives in the book that I talk about where you have these men who will say, rents are so expensive. You have to pay for your laundry and food. I'd rather stay with my parents. My boyfriend comes home and he's seen as my best friend. My mother knows his favorite dish. She celebrates his birthday. What more do I want? Yeah. So, this is actually, there is a Singaporean guy called Chris Tan who's written a book called Go Home, Gay Boy. Why do you need to come out? You can actually go home. Right. So these are just some of the ideas I'm talking about in the book. But of course, which is not to say that, so, being best friend also means that your intimate relationship status is something that is erased. So nobody knows that what is the relationship here. Actually, you are seen as best friends, right? So your sister on her wedding anniversary is going to get probably a very expensive jewelry set. There's going to be no wedding anniversary for you. You're always going to have a best friend who has a birthday, or on uske birthday pe kheer बनती है घर में, हाँ? So yeah, so it's not, I'm not saying that, but I'm saying that this was the bit that I was arguing there, that Indian Western, I mean, these things work differently, and we don't have to think of people who don't come out as somehow psychologically compromised, or psychologically stunted, or not developed enough in that sense. Thinking about stage models of development, because there was a time in the 1980s where in LGBT psychology they were talking about stage models of development, and they were saying that coming out, pride, integration, all those were steps that meant that you were now really truly living a full happy gay life. Yeah. So I think, to the question of does it harm having Western models in the Indian context, as we are saying that right now there are, in a mainstream way, there is no training. So it's not like we are bringing some Western models and applying them here. But I think specific to currently some of the questions, I think two things. One is there is a person called Jagruti Mandrekar. People who are listening can maybe look up her work. One of the things that Jagruti is saying is they run a support group, LGBT support group called Sahas in Bombay. And one of the things they're saying is that families are a very important thing in the Indian context. And we have to actually, when we are thinking of therapeutic work, we'll have to natal families and how do we engage them. And it's complex because we have son preference, we have patrilineal, and this my eldest son who's supposed to be the bearer of my family name turns out gay, or worse, decides to come out and say that I'm a trans feminine person. I don't see myself as a man at all. The devastation that that causes and the consequences that that causes in the family, both for the person in terms of violence or discrimination, but also what happens to the family and parents and the kind of loss they experience. So I think there is that. And similarly with women, this idea of the daughter being the honor of the family, and if she were to come out as lesbian, what would be the meaning of that? So family in the Indian context is quite, it's both a major source of support for people, and it can also still be quite complex. So I think those are some of the kinds of areas that we need to build a little more work on, more than what we have. That's one. And the other is just quickly to say that we have, in fact, one of the oldest histories in the world of having gender diverse communities, with local, social, cultural, religious, sort of different names in different parts of the country. So Hijra, Kinnar, Arvani, all of these communities that have been there. So when we today talk about trans affirmative care, gender affirmative care for trans people, and we are thinking of protocols. Of course, there is this new law which is, I don't know what it's doing, but in that context, we'll have to keep some of these Indian realities in mind. And look at how we are thinking of gender affirmative care, for the spectrum that is there of gender diversity in the Indian context.
Right. Right. Absolutely. So, my next question is for all three of you. Since we are talking about queer affirmative uh, practice and training in that area, what exactly are we trying to teach? Like, what competencies are we looking at beyond the toolkit, and how do we assess those competencies? How do we know that someone who's undergoing the training has truly learned those competencies? Dr. Tirthankar, would you like to go first?
Um, Honestly, the problem, I'm speaking from a very health oriented and medical education oriented background, not from a psychotherapeutic background. Now, in the recent curriculum that has been proposed by the National Medical Commission, the curriculum has become competency based. So they have divided many of the domains of the things that we teach into knowledge domain, skill domain, and the ethics, attitude, and communication domains. And they have also proposed various kinds of, and trained the teachers on various kinds of evaluation techniques. I'm not getting into details of that because we all know that every technique will have their golden ages, and also they will have their fallacies. So that is always there. My question is, queer affirming practice related chapters constitute a domain of knowledge, of that of a skill, or of that of and therefore in order to evaluate, we have to also evaluate in a very objective manner that can become subjective at times, as to whether the knowledge that I have regarding the queer community as a lived human community is adequate and correct. Second, whether my skills related to, say, interviewing an individual, using a particular pronoun, knowing the nuanced contexts of the LGBTQ culture and subculture in my locality and the vernaculars related to that, whether that is accurate. And finally, whether my perception, attitude, and ethical intonation towards the queer community is correct. Now, the first two can be, to some extent, structurally assessed. When you come to perception, ethics, communication, and attitude, they are more manifested during practice. And I have someone's ethics communication intents in medicine, one thing that I always do is not to make it an examination on ethics and communication. Just give them, quote unquote, a situation or a case and see how they handle it. Now, in the score sheet that you hold in your hand, there are no points for the right diagnosis. It's all about how they are interacting, how they are talking. So instead of giving them a difficult medical diagnosis, you give them a person with a difficult behavior. The diagnosis may be very simple. It can be a very simple case of, say, iron deficiency anemia. You see how that uh, budding clinician is dealing with this individual who is difficult to deal with from various perspectives. Probably the person doesn't communicate, the person is mute, or probably this individual has a tick which makes them look different. So there are various ways of testing that, I personally feel. Here also, in the context of assessing the attitude and ethics towards a queer individual, the best way to treat is to present to you someone who happens to be queer and also has a diagnosis which is easy to diagnose. It's important to see how the queer identity gets addressed and also not blended with the psychiatric category in the DSM, making it like a homosexual depression or lesbian anxiety. So while that identity is very important, because the dissonance that the person is feeling might have its roots in the identity also. So we cannot disregard the identity. At the same time, we cannot make the identity the diagnosis. We have to dissociate the individual sexual identity and gender identity, also dissociate the disease, so that when you are giving a therapy, the therapy becomes a therapy for depression, not a therapy for homosexuality. So that distinction should also be there. It's very complex. So you cannot undo with the fact that the depression stems in a homosexual person, because their circumstances are not same. They, as KP has said, things are epistemologic. We come from a location, and that location has a great deal to do with how things happened and why it happened only to me. So we cannot totally silence that, but also we cannot make that location the diagnosis. We can acknowledge that location, understand how the diagnosis came out of that, and at the end, I think, just like we say for physicians, I think a good psychologist is one who at times makes no diagnosis. I think that is also very important. You may have a lot of perception, a number of notes that you took, a number of discussion session, but you may not have a categorical diagnosis as per the diagnostic manuals. So any kind of dysfunction that arises or stems from the intersection of society and the individual is not an individual disorder. Then we are, it's almost like saying that uh, when the neurotransmitter theories of depression and anxiety were very emerging, and the so-called Prozac movement was on, so it was very promising because we had a therapeutic target. We understood how things are changing in the brain, even though we could not ascribe cause effect relationship, but we had something to develop a pharmacotherapy on. But the problem that it also creates is, it's like if your boss or superior is constantly abusing you, you develop depression, and then we say that it's because of low monoamines in your brain. So it now becomes your problem, and the accountability of the abuser totally goes away. In the same way, when a queer individual comes with a specific diagnosis, we have to address the diagnosis, understand how it developed, whether related or unrelated to their being queer, but we also have to dissociate the queer identity at one point from the diagnosis. Otherwise, we ascribe the queerness to be the cause of the diagnosis, which again may be inappropriate in certain cases. So I think KP will be the better person to talk about this, and also Dr. Lata, because I think this is very nuanced. There is no point where I can draw a line and say this part is my domain and this is not the domain of therapeutics or diagnostics. And learning that skill is the thing I think you are talking about. To intuitively understand this. And from where does intuition come? Intuition is not sixth sense. It's extrapolation of our learnings and observations. If you are a keen observer, if you are an empath, if you can put yourself into the other people's locations and then see how they see the world, I think that makes all the change. You know where to draw the line for whom, and that too with consent.
Right, right. So beautifully put, Dr. Tirthankar. I think how you highlighted the role of an empath is uh, wonderful, and probably it sort of ties with the perspective taking that we were talking about in the beginning. And that is one skill or one competence area that is sort of constantly coming back through what Dr. Lata also highlighted in the lived experience part. Ma'am, any other thing, any other competence area that you think is important as a part of the QACP
Yeah,
training?
I think being self-reflective, I think is a very important aspect of it, because I think you need to check what are your beliefs, what are your standards of morality and appropriateness. So unless you are able to align into the world of the client comes and provide safety for that person. So how do we align? I think that the process of reflection can help you to do that. Like what Dr. Tirthankar was saying, making observations without any judgment, and being able to navigate through that.
Right, 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 right. Thank you, ma'am. And I will come back to you with one question on supervision in some time, which probably is related to this. But
Yes.
before that, Dr. KP, anything uh, in this, any other input from your side?
So just two quick things. One is just to reiterate the bit about self-reflexivity of the therapist. I think particularly when it comes to sex, gender, sexuality, one of the things I have been doing, it's there in the resource book, QACP resource book, but also when I am currently teaching this course at TIS. I think it really helps people to do. We ask people actually to not start from a queer trans lived experience. We start from actually looking at whoever you are, and start to look at, for example, what are some of the. So one of the exercises I do in one of my first or second class is to ask people to map what are some of the earliest gender messages you received in your life. Where did you receive them from? What was the source like? Did these messages change over the years? Did you defy any of these messages? What were the consequences? Uh, are there gender messages that really worked for you, that make you happy? Right. And similarly, we ask stuff about sexuality, that when was the first time that you received a message on morality around sexuality? Who was the person who was giving you that message? So actually really doing this work with oneself on gender, sexuality, our own life, before really going into clients, and particularly if the therapist is a cisgender heterosexual person, then I think that's a very good place to start from, is my sense. And then also to reflect on, people do reflect on how their gender and sexuality is actually in some ways connected to their sense of well-being. And so I think some of these examples of reflexivity are really helpful, what Dr. Lata was saying. In terms of other competence, I also think that it's important to remember that queer, trans, affirmation, etc. is a lens. It's not a therapeutic model. So, you could be doing CBT, you could be doing attachment based therapy, you could be doing whatever, family therapy. What you're doing is you're bringing this lens to, I think what Dr. Tirthankar was also sort of emphasizing, is to bring this lens to this therapeutic work that you may be doing. So, there's minority stress, I think, is something everyone must have heard of, this idea of sexual minority stress. But there's another interesting framework called psychological mediation framework, where this person, his name is a bit difficult to pronounce, Hudson Bueller, who talks about general psychological processes superimposed with minority stress. So there could be, for example, sibling rivalry, which is a general psychological process, right? But the sibling rivalry also is that my sibling has a very normative life, and she's therefore really made my parents happy, and she's been able to, match all the social milestones, right? So it's never one without the other. Yeah. But their sibling rivalry is also still a very real psychological process that everyone goes through. There is a queer aspect to it. Not everything is queer, and yet there is queerness in most psychological. So how do you do this in terms of competence? I think that's an important thing to look at. Yeah.
Right, right, right. And on that note, I can see there are a lot of practical skills and a lot of experiential activities which are being used to understand certain perspectives better. So, what kind of methodology really works when it comes to QACP training? What is most helpful?
Would you like me to respond? I mean, I think Dr. Tirthankar also uses a lot of film and clubs and things like that. Uh, do you want to? Yeah, I don't know who wants to respond.
Maybe the
I think
you
Katie
can.
goes first because
No, I think what works, I think reflective exercises are extremely helpful. Case discussions of people you have worked with, so getting people to do this work in groups and things like that. So apart from theoretical perspectives, and I mean, I can't emphasize enough on knowledge models because existing models are exclusionary to some realities, and so therefore we must have emphasis on both theory and research. But there's also something to be said about using films, film-based discussions, using literature to teach some of these lived experiences. Sometimes you can actually have people come in and share their life lived experience. Sometimes you can watch a film and talk about what the protagonist is experiencing. So I think all of these in terms of pedagogy are quite helpful.
Absolutely. I don't know how many of you have watched Piku Bhalo Ache. This is one of the many films that Dr. Tirthankar had directed, but this was his, I think, first, if I'm not wrong. And we had just started knowing him, and how understanding what exactly a homosexual person might go through. That it's a beautiful, poignant movie, and I think the last scene stays with me. After 10, 15 years, or maybe 20 years, I was rewatching it a few weeks back, and I sent him a screenshot saying that it still leaves the same impact every time I watch it. So it does, movie or any form of art for that matter. So Dr. Tirthankar, what is your take on using any form of art, particularly films, um, for training?
thank you for those words of appreciation. Uh, I have always been fascinated with art because I never wanted to be a doctor, to be very honest. Now, I ended up being a doctor. Then again, I went back to academics because that was my forte. I mean, teaching is closer to art and performance. Um, Art liberates us. Art makes us question. There is this very popular line that we keep saying, which I really believe in, that a good art should make the comfortable uncomfortable, and it should also ease the one who is already under distress. So, the dysphoria that you create through art in the still waters and the stillness that you bring to a soul who is crying out, this contradiction is what the art is built up of. So art has a great resource. I do not always believe that art has to have a singular objective purpose. I'm not saying art for the sake of happiness, for the sake of creation is not art. But even maybe not now, maybe 20 years later, it can start bringing up a question. It's almost like differentiating science from technology. When we talk of technology, we ask what good will it serve to the humanity or to the environment or to something. But when we talk of pure science, we simply ask, maybe what we ask today becomes a tool of technology, or even may not become a tool of technology 20 years later. That does not invalidate the question. So, using art has been liberating for me because being trained in natural science based courses throughout my life, the medical sciences that they are, I have found that these sciences also, although we say that science is very liberating, I found scientific studies, by its intrinsic nature, to be a very convergent way of thinking. Because if you conduct the same experiment in 10 different places under the same ideal condition, you have to expect the same result all the time. And it is this convergence of science that at times takes away the charm out of it. It makes it very monolithic, it makes it very institutional. And at a point when you stop questioning whether the principles that are written in the books are right or wrong. And that is the point where the science becomes an organized religion. And that is what I fear the most. When art intersects into these natural sciences, it stops it from becoming an indoctrinated religion. And that is where I use art.
That is such a powerful thing to say, I
Wonderful.
think.
Wonderful.
Right. And I think this is like so impactful. Everyone is sort of taking it in. I'm also mindful of the time, so we'll sort of quickly move on. But I wish I could stay with this thought forever, not forever, but for a longer time, just to stay with it.
Yeah.
So quickly, because we have very little 10 minutes left now with us, Dr. Lata, you had supervised so many people across so many years of practice. When you supervise anyone in the queer affirmative lens, is it different? Does supervision look different than the usual supervision, or is it the same where we are just probing into the lens like we do?
I must confess that there have been very few who have had clients who have come for supervision to. But what I can reiterate, having supervised on uh, different cases, different people, I mean, of different trainings and so on. What I can say the most important part of supervision is to be able to reflect both the supervisor and the supervisee about their observations and how far can the supervisee align themselves to the inner world, the client. So I think that is the most essential part of supervision. I would think how seeing the client, uh, being with the client, dealing with the client, what are the emotions that you go through? So these are things which need reflection, and that's what you do. I think that's the quintessential part. Whether I feel it may be similar even in their affirmative counselors.
Right, right. Thank you, ma'am, for sharing that. And Dr. KP, what about the trainer? We are talking a lot about curriculum, methodology, supervision space, but the trainer in the QACP program, do they need to have certain characteristics, certain things that like these are the standards they have to meet, these are the things they have to know before they qualify as the trainer? Does the identity, be it the sexual identity of the trainer, does that also play any role in delivering the training?
I think I mean I don't believe in prescribing who should be an ideal trainer or a trainee for the QACP or a queer affirmative transition. But I mean certainly I think competence in terms of knowledge. So, which means one must sort of be connected with research in this field, no controversies that are there in this field. So, if you're somebody who's working on, let's say, trans affirmation, you must know about the dialogues that are happening now, for example, on detransitioning, or so some of these controversial issues that are there, or of course the amendments in the law that have now come into force last month. So I think, in my mind, anybody who is invested. Both in terms of the psychological theories around queer and trans affirmation, but also in terms of policy, legal debates, very connected to community initiatives, I think is very, very important. I mean, whether, I mean, of course, if you have your own experience experience as a queer person, as a trans person, as somebody who's an ally, as somebody who's a family member. There are some very, very good people I have seen. There are some questions I think about family. I have seen some amazing work done by advocates who are parents, and parents who are actually really, really pushing the envelope in terms of mainstream training, pushing also bureaucracy, policy, etc. So I think, yeah, so it's actually a community of us who can do some of this work. Self-reflexivity, of course, is very, very important. But I mean, I think its attitude is important, but also competence is important, not one for the other. Sometimes I think that just lived experience may not take us very far. It can only, I mean, it can do, of course, it can do a lot of work of empathy perspective, but that may not be enough. So I think there is also, it's important to have both competence, training oneself, and yeah, to be aware of contemporary issues. Yeah.
And today we talked about queer affirmative practice. We talked about trainees training. The other thing, which is also a fad, I guess, is queer affirmative organizations. What actually pertains, or what exact? How can we call an organization inclusive, queer affirmative? What policies should ideally be in place to call an organization queer affirmative? And this question is for all three of you.
So, so organization
Okay, I'm
adopt a
starting since there is a deafening silence. I think you are asking questions. Yes, Dr. Lata. Dr. Lata, please continue.
I think it should have a policy of non-discrimination, which implies that the same care is provided for all people. So I am speaking from uh, the point of view of sort of leading the research fellowship, which is involved in rehabilitation. So to take an example there, so we follow the what is called the therapeutic community method, which means that the whole community is uh, is is therapeutic. Their interaction and lived experience itself becomes therapy. So that's the rationale. So we have a queer person who I think comes from a very affluent family, and somehow the family could not integrate them into. They feel a little awkward to have him around, and they have placed him here. So he had this habit of if he likes a person, he calls them cute and he starts pinching their cheeks. Like I said, whole community becomes therapists, so they do give him a feedback. Those who feel uncomfortable when he does that, they give him a feedback, and he takes it well. But there are others who enjoy it, who like it, and who allow him to do it. So the staff have been sensitive to being queer, and, you know. So what are the kind of books they might have, which get suppressed because of the way they have to do. So when they get a chance and somebody is willing to accept it, we have to we don't have to follow the rules to the T, and we can be a little relaxed about it. So I think I bring in that perspective to the professionals who are there. So I think in every big organization, at the decision making level, there should be queer affirmative practitioners. That's my take.
Thank you so much, ma'am. That is very helpful. Dr. Tirthankar, you wanted to go next?
Yes, like I was thinking that you are asking questions that will put my or many of our jobs at risk. Because, yeah, there are no ideal queer affirmative organizations I really know of. Mm, but see, apart from uh, the way an organization is supposed to behave, I think what really makes it inclusive and affirming is how they have policies written in their modus operandi. And I emphasize on published or written policy making because in my real life, I have seen many human beings, many individuals I've crossed path with who are very affirming. They might not have the level of an organization on them. Sometimes they have been one isolated teacher I have met. Sometimes they have been some of my students. Sometimes they have been a distant family member. There are, or simply an acquaintance. So, queer affirmation is at one point of time is also a personal attribute, and it's not possible technically that you build an organization where there is a measurable degree of queer affirmation in every one of them. I mean, that is very ideal, but from a very logistic point of view, how are we going to measure this qualitative variable unless they are put into actual practices and situations? So one thing that I can always rely upon is the written policy of the organization, things being legislated, and things that are within the preview of the current legal status of the state, perhaps not outspoken, which have been imbibed and the organization has taken one step forward. That is something I see as a very progressive step. I'll give an example. Right now, Section 377 is partly decriminalized or read down. Second, gay marriage as such is not right now legal in India or institutionalized in India. So I cannot get a marriage certificate. Now we know that marriage is not just a romantic or family bond. It also comes with various kinds of financial, property-related aspects, which are our fundamental rights. Like if I wish, I cannot directly make my boyfriend a nominee for my LIC policy. That will take a lot of paperwork to be done. I cannot add the name of my boyfriend into my beneficiary at a hospital where the medical insurance will be shared by us. So now, I will call an organization pro queer and proactively queer affirming when, see, there is no legal obstacle also in assuming that any one person can be a nominee for my say official accounts of the salary that I get. So if they relax the rule in a manner that any one family member or friend or acquaintance or intimate partner that have both of them have consented to becoming the nominee can become a nominee. That does not take away anything from the organization. At the end of the day, organization needs the name of one nominee, and it does not have to be a blood relation or a cis-het marriage relationship. So at the end of the day, if they have to give this money to one person chosen by me, and if this comes as a written policy from the organization, even in the current structure of the law and the society, it becomes a queer affirming step. In my institution alone, I can cite an example. There are provisions for adding three names of family members who can get subsidized treatment in my own hospital because I'm a staff. But it comes with criteria. It comes with criteria that the person has to be So if an organization is already willing to pay subsidy to three of my family members, and if they give me this liberty of choosing which three that they are without setting in boundaries of a cis-het normative society, that is what I call progression. So I think written policies are important. Practices are more important, of course, but practices are something that is very subjective. It evolves with the work culture and it is contextual. Written policies are something that we trust and get in first. Then we can come out saying that what they preach, they don't practice. That is always there. But I think things should be in writing into their policy or manifesto or in their job description. And that is something that encourages queer people to join that organization. Thank you.
Thank you. Thank you. And Dr. KP, would you like to add anything, particularly to the lens of a queer affirmative mental health organization? Anything?
I think you mentioned mandatory training. Mandatory training, CME kind of continued medical education, similarly, some sort of a training for people who have, maybe even educated way back when conversion treatments were okay or homosexuality was a crime, etc., etc. So, some kind of continued education. And maybe having points for that. Like I know RCI has points, but many other mental health professionals don't have much motivation to have continued education. So I think some of those things, as mandated within a mental health organization, that might be useful.
Thank you. I think we have come to the end of our conversation, and I can't thank you enough, three of you enough, for lending in so much of knowledge, perspective. Um, I think everyone who was listening to it was sort of also becoming like we also aware in a somewhere in the path of our affirmative journey, like we also shifted a bit, we moved a bit in a direction which towards an inclusive space. Like again, going back to the air that we are talking about, I think we were shifting the air around. I today, as as a part of TherapHeal, I also commit that, like I started off saying what is our responsibility. I think while we were talking, I also had some idea about what is my responsibility as a clinical psychologist, as an individual, as a mother, and as someone who is heading therapy. There are many responsibilities that I have to do, and I commit to that. That I'll try my best to do whatever can and should be done. And I hope we all are leaving this conversation with that in our head, that we will do our little bit. And like Dr. KP highlighted, that there's so much happening, there's so much hope, there's so many silent fighters, there's so much support. And that is what is still letting the balance go. We are still not off balance, despite acts like the recent trans acts coming in. We are still not off balance. So thank you so much for for your time, for your wisdom, for your inputs, Dr. Lata, Dr. KP, Dr. Tirthankar. Thank you so much. Any last thing that any of you would like to end with?
Thank you. Happy to have been here, and thank you to the wonderful co-panelists as well, and to the moderator. Had a good time. Thank you.
Thank you. Yeah. It was good to see KP and Dr. Tirthankar. Yes. Yeah. And I salute
Same
the
here, same here. It was
resilience
a fabulous
of
experience.
I salute the resilience of the queer community.
Absolutely. So we end with that. We all
Thank you,
salute the
madam.
resilience of the Cure community. Have a great evening and see you all soon. Thank you.
Thank you.
Thank you. Minu, can you help us exit, please? Minu, can you